60-year-old male with refractory depression scheduled for electroconvulsive therapy. Describe the anesthetic management. Okay, so that is the question. So ECT anesthesia is provided at remote sites. So all appropriate resuscitation equipment and other drugs should be readily available. And first thing you do is a preoperative assessment. Take a thorough history of how long the depression has been there, what are all the psychiatric treatment the patient has taken, what is the other comorbidities that he is having, what is his effort tolerance, everything should be taken. So this patient is elderly and have variety of comorbidities, can be poor historians. Because of the psychiatric illness, they may not be able to tell the history properly to you. So you have to depend on the informant, like relatives. And conditions like raised intracranial pressure or a recent CVA or untreated cerebral aneurysm, myocardial ischemia, uncontrolled cardiac failure, if these histories are forthcoming, or unstable major fracture, osteoporosis, then these are all considered as contraindications to ECT. Okay, so you must probe and find out whether these conditions are present, which the patient may not be able to say. So you have to get it from the attenders or relatives. And again, pheochromocytoma, very high BP, uncontrolled blood pressure, retinal detachment, glaucoma, cochlear implant are also contraindications for ECT. So by taking a proper history, you must rule out that these things are not there in the patient. And many psychiatric drugs have either variety of side effects on their own, or they may interact with your anesthetic drug. So you must take a detailed drug history. So the first part of the history is about comorbidities. Second part of the history is evaluating for any contraindication diseases that may be present. Third part is the drug history, and you must elicit that and document it. And of all the drugs, you need not mention the names and varieties of each and every drug, but you can just simply mention like drugs like SSRIs, they can cause SAADH, or lithium can cause nephrogenic diabetes insipidus, and tricyclic antidepressants or MAO inhibitors may have hypertensive crisis if pethidine is used. And so these main drugs which have their interaction or the side effects, that alone can be mentioned and we can stop there. And then examine the patient physically. For example, you to look for any cardiac failure, valvular disease, dysrhythmias, uncontrolled hypertension, poor dentition, dehydration requiring fluid therapy. So clinical examination of that patient should be done. Then investigations. Third part is the investigation. Routine blood test, ECG, and other investigations as indicated. Supposing cardiac failure is there, you must ask for an echo and cardiology consultation. Then coming to the conduct of anesthesia, consent should be checked. Patient should be adequately fasted. So during the preoperative, pre-anesthetic time itself, you advise about the fasting because this is an elective procedure. And whatever regular medications the patient has been taking should be advised to continue, except the tricyclic antidepressants or MAO, which can be stopped 10 days prior to that. And sedative medication is usually avoided because it can reduce the seizure activity. And glycopyrrolate is administered to counteract. Usually, ECT has a biphasic response. Initially, it produces a predominant parasympathetic response, which causes bradycardia. And secondarily, after that, it produces a sympathetic stimulus a little later, which causes tachycardia and hypertension. So during the initial parasympathetic response, the patient may have severe bradycardia and sometimes even cardiac arrest can happen. So it is always better to give glycopyrrolate. Atropine is preferably avoided because it crosses the blood-brain barrier. So it is better to use glycopyrrolate, which will also reduce the secretions that can be produced by some of the anesthetic agents. And patients should empty their bladder because incontinence can happen and they can void on the table during seizure time. So always insist that they use the restroom before coming for ECG. Then the drugs of choice, propofol you can use in this dosage, etomidate, tipentone are all the drugs for induction. I have not specifically mentioned methotrexate, even though textbooks say that methotrexate is the drug of choice. It is not commonly available. So whatever drugs that are easily available, these are the three drugs that you can mention. And neuromuscular blocking agents reduce the muscular convulsions and decrease the risk of serious injuries like fractures or their muscle tear and other things. So you always give a small dose of muscle relaxant. So for that, suxamethonium, which is a sub-intubating dose or a sub-relaxant dose called 0.5 milligram per kg is used for this purpose. And if supposing for any reason suxamethonium is contraindicated, then you can go for mivacurium, which is a non-depolarizing muscle relaxant, but having a very short action. So 0.15 milligram per kg can be used. And nowadays, because we have Sugamidex available, people are using rocuronium and vicuronium also as a pre-curarizing agent, not at the intubating dose, but it as a sub-intubating or a sub-paralytic. This is called sub-paralytic dose. So that can be used. And deleterious sympathetic effects may be controlled by beta blocker therapy, either atenolol as a preoperatively or intraoperatively. You can use the conventional labetalol or esmolol. And alpha 2 agonist dexmedetomidine also can be used to blunt the hyperdynamic response, which happens during the sympathetic stimulation after the initial parasympathetic stimulation. And calcium channel blockers can also effectively control the arterial pressure. Then coming to airway management, the first step is patient is pre-oxygenated, and after induction, ventilation can be gently assisted with the face mask. Then inserting a bite block protects the patient's teeth and lips. Then after that, when the patient is partially apneic or mildly breathing, and unconscious, you hand over the patient to the psychiatrist. And the psychiatrist will apply the electrical paddles. It can be done as two procedures. Remember, do you know what are all the methods of the electrical stimulus applied?
Yes, sir.
What are the types?
You asked about electrode position, sir.
Electrode position and the current applied.
Electrodes, two scalp electrodes are applied, sir. It can be bitemoral scalp electrode or right unilateral electrode, which is also called de-Elia positioning. One electrode is placed on the right dimple and the other electrode is placed on the right of the vertex of the skull. And lastly, bifrontal electrodes placed above the outer canthus of the both eyes, sir.
Very good. So it can be bilateral or unilateral. It's a very short current that is given. So it stimulates so during the current application, preferably not to touch the patient because the current will pass on to you also. So after you have ventilated and filled the lungs with oxygen, you hand over the patient to the psychiatrist who will give the current. And once the seizure sets in, then you can again apply the mask and then start just doing a hand ventilation. And post-operative considerations are standard monitoring should be applied during recovery also. Intraoperatively also, these monitors sometimes, they may not be functioning properly because the patient will throw a fit. So at least a pulse oximeter and the ECG monitor can be fixed. And oxygen supplementation continued until oxygen saturations are adequate on room air. And common side effects are confusion, agitation, violent behavior, etc. For that, you can, after the seizure is over, you can give small doses of midazolam. So that will not interfere with any further resistance. And most patients recover quickly and can be discharged according to the standard criteria. So these are all the points that you are supposed to mention. Don't forget to mention about the remote site anesthesia as Nora as the first point. Okay, and all other things are mentioned nicely by Janama that can be used.
Okay, sir. Thank you, sir.